Dr. Farah. Our subject today is intervertebral discs. First, we will discuss introduction, gross anatomy, nerve and blood supply, radiological imaging, and a few pathological notes. The intervertebral discs form the articulation between adjacent vertebral bodies. They account for about 1/5 of the total height of the vertebral column. The discs are wedge-shaped in the cervical and lumbar regions, but are flat in the thoracic regions. The wedge shape in the cervical and lumbar region contribute to lordosis in this area. The vertebral bodies are joined by fibrocartilaginous discs, which are adherent to thin cartilaginous plates on the vertebral bodies above and below them. As we see in this picture, this is the intervertebral disc between the two vertebrae above and below. These joints are considered amphiarthroidal joints that allow only slight movement and found at the skeletal midline. The major components of the intervertebral disc are the nucleus pulposus, which is located centrally, and the annulus fibrosus, which is located peripherally, and the cartilaginous end plate on the vertebra above and below. This is the nucleus pulposus with the peripheral annulus fibrosus, the cartilaginous end plate on the vertebra. First, we discuss the nucleus pulposus, which is located centrally, as we mentioned earlier, and is composed of fibrocartilage, predominantly type 2 collagen and proteoglycan, being gelatinous in young subjects but become more fibrous with aging. This is the nucleus pulposus and annulus fibrosus with the vertebral end plate. The annulus fibrosus attached anteriorly and firmly to the anterior longitudinal ligament, as we see in this axial view of the intervertebral disc. But posteriorly, it's loose attachment, and it's usually the site of rupture in the degenerated disc. It's considered as highly laminated, ordered laminated structure that's divided into an outer and inner rings. The outer ring inserts into the ring apophysis of the adjacent vertebra and the adjacent cartilaginous end plate. This image shows us the ring apophysis and the cartilaginous end plate. That's the site of attachment of the outer ring of the annulus fibrosus. The third component is the cartilaginous end plate, which also have two parts. The peripheral part, which is the fibrocartilaginous that cover the apophyseal ring here, and the central part, which is hyaline cartilage and cover the vertebral end plate. This picture summarizes what we discussed earlier, the major components of the disc in the between the vertebral bodies. This is the centrally located nucleus pulposus, the peripherally located annulus fibrosus with its two zones, the inner and outer zone, and this is the cartilaginous end plate, which is centrally composed of hyaline cartilage and peripherally of fibrous cartilage. Now we will see a short video about the anatomy of the intervertebral disc.
Between the vertebrae are a number of complex joints, but the ones we're interested in today are the large fibrocartilaginous joints between the bodies of the vertebrae. More specifically, these joints are between the inferior end plate of the vertebrae above and the superior end plate of the vertebra below, like this. We call these joints fibrocartilaginous because they consist of a mixture of white fibrous tissue and cartilage, which gives the joints a unique combination of strength and elasticity. Anatomists refer to these fibrocartilaginous structures as the intervertebral discs. There are 23 intervertebral discs, the most superior lying between the second and third cervical vertebra, and the most inferior lying between the fifth lumbar vertebra and the sacrum. Although there's some variation, the discs generally get larger as you move down the spinal column. We name the intervertebral discs after the vertebrae they connect, for example, the C2-C3 disc or the L5-S1 disc. All 23 of the discs have a similar structure, composed of an outer fibrous ring, known as the annulus fibrosus, and an inner gel-like center, known as the nucleus pulposus. At their top and bottom, the discs have an interface with their adjacent vertebra, known as the cartilaginous end plate. A healthy disc is symmetrical, with the nucleus sitting in the midline coronally, deviated slightly towards the posterior. Let's look at these areas a bit more closely. The annulus fibrosus is composed of a series of 15 to 25 concentric lamellae, with collagen fibers arranged in alternating complementary directions at 60 degrees to the vertical axis. Between these lamellae are glycoproteins, proteoglycans, and elastin fibers, which trap water and help the disc return to a normal shape after being stretched. You can further subdivide the annulus into an outer and inner portion, with the outer containing mostly type 1 collagen and the inner containing increasingly greater proportions of type 2 collagen as you move towards the center. Anatomists will sometimes refer to the inner annulus as the transition zone, as it gradually transitions into the nucleus. The annulus is strong and tough and acts to contain the softer nucleus inside, as well as holding its two vertebrae together and withstanding mechanical forces acting on the spine. In contrast to the annulus, the nucleus pulposus is composed mostly of water, which is suspended in a matrix of mostly type 2 collagen and proteoglycans. The arrangement of these structures is much looser, as the nucleus is not intended to withstand mechanical stresses in the same way as the annulus. Instead, it acts to absorb compressive forces as the spinal column is loaded and redistribute these forces to the surrounding connective tissues. The flexibility of the nucleus also allows it to move around a little within the intervertebral disc, increasing the flexibility of the spine. As people age, the nucleus becomes more rigid and gradually transitions from type 2 to type 1 collagen, reducing its usefulness as a shock absorber and reducing the flexibility of the spine. Lastly, the cartilaginous end plate is composed mostly of horizontally arranged collagen fibers at the interface of the disc and its adjoining vertebral bodies. These end plates play an important role during growth, as most of the nutritional supply to the disc diffuses across them. However, in the adult, calcification of these end plates eventually leads to the devascularization of the disc.
Nerve supply is somatic and autonomic supply from recurrent meningeal nerve of Lucica, which is or the sinovertebral nerve, ventral ramus, dorsal ramus, and sympathetic fibers that is arising from the paravertebral autonomic plexus. This image show us the sinovertebral nerve or the recurrent meningeal nerve of Lucica, the ventral rami, dorsal rami, and the sympathetic fibers that is arising from the paravertebral autonomic plexus. Arterial supply is by the ascending cervical artery, intercostal, and lumbar segmental arteries. These are the ascending cervical, intercostal, and lumbar arteries. Venous drainage is by a pair of basivertebral veins that are emerging from the posterior surface of the body and drain into the internal vertebral venous plexus, and these drain into the segmental veins. These are considered large valveless veins that allow reflux of blood and considered as a potential route of disease separate into the vertebral bodies. This image shows us the basivertebral veins here, which are drained into the internal vertebral vein, then into the segmental vein. Radiological imaging. Firstly, plain radiograph. The disc space rather than the disc itself is visible. We should note that the disc space at L5-S1 level is narrow, and this should not be taken as a sign of disease. This image is of an X-ray of the lumbar spine taken laterally. This is L1 vertebral body, and this is L2 with the intervertebral disc space between them. This is L5 and S1. We see here that the disc space is narrower than the disc above it, and it's normal and should not be confused with disease. Second is the discography, which is performed by injection of contrast medium into the annulus fibrosis through the nucleus pulposus, as we see here in this image, usually performed in the lumbar region. It can be performed either posteriorly through the dura or posterolaterally without going through the dura. The normal disc should be smooth, central, unilocular, or bilocular nucleus pulposus, and contrast medium should remain within the confine of the annulus fibrosis. These are the needles that are going through the disc space, through the disc. This image shows us that L2, L3 disc space is normal, while L3, L4 show a small posterior inferior tear, and L4, L5 disc show decrease in height and also had extensive annular disruption and posterior protrusion. CT. The intervertebral discs are low attenuation, and it's not possible to distinguish between the nucleus pulposus and the annulus fibrosus. Here are the vertebral bodies as seen in this image, CT. This is the inferior end plate of the vertebra above with the superior end plate of the vertebra below. This is the nucleus pulposus with the annulus fibrosus, but we cannot distinguish between them on CT scan. This is a sagittal lumbar CT scan. This is an axial view of CT scan. And the last modality is MRI. The nucleus pulposus, as we mentioned earlier, which is located centrally, have rich water content and seem hyperintense on T2, while the annulus fibrosus have poor water content. We can divide them into an inner and outer. The inner seem to be indistinct, have indistinct boundaries with the nucleus pulposus, while the outer is hypointense on T2. This is a sagittal view of lumbar MRI. This is L1 vertebral body and L2 with the intervertebral disc between them, nucleus pulposus hyperintense and the annulus fibrosus hypointense. This is another image. The water content of the nucleus pulposus in youth high as 80%, although this decreases with age. The vascular supply to the disc decrease in maturity. In infants and during childhood, they have a network of vessels both supply the outer annulus and penetrate deep into the disc substance, while in adulthood, deep penetrating vessels are not identified, only vessels supplying the outer annulus alone. Supply to the annulus is thought to account for frequently identified enhancement of the outer annulus in up to 60% of cases. Enhancement reflecting vascularity appeared to increase in the annulus of the degenerative disc, most likely reflecting local inflammatory changes. This is another image of MRI T2 sagittal view. This is the vertebral body with the intervertebral disc between them, superior and inferior end plate, anterior longitudinal ligament, and posterior longitudinal ligament, ligamentum flavum, interspinous ligament, and supraspinous ligament. Intranuclear cleft, which is a septum-like structure that transects the middle of the nucleus pulposus, seen on T2 weighted images as linear area of reduced signal intensity that is located in the center of the nucleus on sagittal view. As we see in this image, this is the low attenuated line that is seen in the nucleus pulposus in the intervertebral disc. And the last subject is some pathological notes. The normal disc space should increase as we go down. As we see in this X-ray, here the disc space increase gradually as we descend down. And in this CT scan and this MRI. Also, we should note that the posterior border should be concave of the intervertebral disc here. And also they should not exceed the posterior border of the related vertebra in this sagittal view. In the degenerative disc, we see that the disc spaces decrease in size. Some of the disc spaces that undergo degeneration show decrease in size. And also there is posterior bulging of the intervertebral disc. If anybody have any question.
اكو احد عنده سؤال الدكتورة فرح قبل ما نروح للكويز؟ اعتقد يعني شرحته شرح واضح ووافي بالنسبة للانترفيرتبرال ديسك. ماكو؟ اوكي. اذا هسه نبدي الكويز. نختار ارسلان. دكتور ارسلان.
الأستاذ name the structure labeled A. هذا الفين دكتور؟
شو هذا؟
فين؟
اي شو يصيحوا لها؟ بيزي فيرتبرال فين.
بيزي فيرتبرال
صحيح او نيوترال فيزز.
بيزي.
دينا question number 2 B.
B. Nucleus bulbosus of L1, L2.
اوكي. This is the nucleus مؤشر على السنتر مال الديسك. دكتورة إسراء عبد الوهاب C.
نعم أستاذ، كونس مدلارس.
كونس مدلارس. excellent. هاجر العنزي
نعم أستاذ.
D.
structure label D. كودكواينة.
كوديكوين. وشنو الفحص هذا؟
MRI sagittal T2.
excellent. هند عماد last one E.
نعم أستاذ. E. anterior longitudinal ligament.
excellent. بس الانتيريور لونجيتيودينال ليجامنت شنو الريليشن مالته ويا الديسك؟
نعم، يكون الديسك فيرملي اتاتش للانتيريور لونجيتيودينال ليجامنت، بينما يكون لوزلي للبوستيريور، ولذلك نشوف دائما الديسك بالج بالايجنج انه يكون بوستيريورلي.
اكسلنت. فلذلك احنا فيري ريرلي نشوف انتيريور ديسك برولابس بينما بوستيريور كمان. تفضل استاذ محمد.
شكرا استاذ رعد. فاطمه هيكل. اي فاطمه.
نعم أستاذ. الأي هو الليجامنتوم فلاغا.
نعم الليجامنتوم فلاغا. سارة توفيق بي.
نعم أستاذ. basic vertebral vein of L3.
نعم. زينب رافد. زينب.
نعم أستاذ. رقم سي هو الانتران سباينس ليجامنت.
نعم. أسماء عبد علي. دي. أسماء ويانا.
نعم أستاذ.
اي
رقم دي نيوكليوس بالبوسس.
دي نيوكليوس بالبوسس.
المطر.
اخير واحد اي.
ازهر.
زينة. استاذ محمد رجعي.
العفو. annulus fibrosis of all 4 or 5.
كم بارت بي الانيولاس فايبروسس؟
2 بارت.
اللي هي شنو؟
الانتيريور وبوستيريور.
لا شلون؟
annulus fibrosis.
باوتر وانر.
اوتر وانر. اي اوتر وانر.
الاوتر يا تايب كولاجين.
كولاجين.
تمكنت ويانا بالمحاضرة؟
لا عمي
كولاجين تايب 1
بيض.
والانر كولاجين تايب 2. اوكي.
بيض.
سام محمد بعدك ويانا؟ سام محمد.
ايه وياكم موجود.
وصوتك انقطع.